Hi, my name is Danielle Carnival, and I'm the Vice President of the Biden Cancer Initiative. We're here today to talk about prevention and early detection in cancer, and we have a great panel with us here. I will have each of you introduce yourselves in turn and answer the question, if we could do one thing as a community, what is the most important step we could take in making advances in cancer prevention and early detection? Thomas?
Thank you. My name is Thomas Bock. I'm the CEO of Heridex, and we are focused on developing preventive therapies for inherited cancer. The most important thing we can do is to create a focus that is as big as the importance of that field. Eliminating cancer requires focusing on intervening before cancer occurs, but science and medicine are focusing on intervening after cancer has already occurred. So if we want to intervene, we have to do this. And I think patients have to, or families who are facing cancer, have to take this initiative, have to bring academia, government, industry together, and funders, because they are the ones who will benefit most.
I'm Carolyn Aldeget. I am the founder and CEO of the Prevent Cancer Foundation. And I think the most important thing that we can do is, as a community, is to motivate people to incorporate in their daily lives everything we already know that would enable us as a population to reduce the risk of cancer by 50%, the number of incidents of cancer and the number of deaths from cancer, just with what we already know. So we just need a big behavior change.
My name is Almer Huerta. I'm a physician in cancer prevention. I'm the director of the Cancer Preventorium at the MedStar Washington Hospital Center here in Washington, D.C. The things we can do to improve cancer prevention in general are at the various levels. For example, at the personal and community level, we need to be much more creative in designing public education programs that need to be focused on different group ages and different populations, but we need to really make sure that people know about the advantages of doing cancer prevention and early detection. Usually when you read papers about the value of prevention and early detection, they only focus on the survival or in the biological endpoints, but they don't take into account the mental health impact of prevention, the happiness, the productivity. So how important is that for a person who does prevention and control? We need to take that into account. And of course, at the policy level, we need to educate politicians, because without laws, there is nothing. So if the politicians are not in the side of cancer prevention and control, we're gonna have a hard time.
Hi, I'm Rich Wender. I'm the Chief Cancer Control Officer at the American Cancer Society, and I really echo all of the priorities. We have to prioritize prevention. We have to implement what's known. We have to take into a broader view of how to affect change. But if I just pick one, I would lobby and advocate for multi-sector engagement around where people live, the social determinants of health, which are very strong predictors of their behaviors. It's very difficult, but if we were to find a solution, it would have the greatest impact. We really believe, because the data supports it, your zip code is more important than your genetic code in determining your risk for cancer and many other diseases.
To build on that, can you say a little bit more about where you may have seen a successful example of that, that we could learn from and build out to other parts of prevention?
There have been some communities who've tackled some of these social determinants, like transportation, like income disparity, like communication, bringing people together. We're fortunate to receive at ACS a $4.3 million Robert Wood Johnson Foundation grant to tackle health equity and create healthy communities, and we're going to be conducting pilots in 12 communities. One of the first will be in the Milwaukee area, and to me that is a good example. We've seen real engagement of the Milwaukee community, recognizing the impact that social determinants have had on health and a willingness to embrace it. We'll have to see how much progress we can make, but that's a good start.
My hospital, the Washington Hospital Center, is located right here in Washington, D.C., at the heart of the city, the capital. We found out 4 years ago that 97% of the women who come to my hospital with advanced stage 3, 4 breast cancer, they do have health insurance in their pockets. So when we went to see the numbers, we found out that at my hospital, we are seeing double the national rate of advanced cancer. Nationwide is less than 10% stage 3 and 4, and my hospital is 22.2%. 97% of them with health insurance. So what we did is to go to the zip codes. We went to see who those women were, where do they live, and we found out the zip codes around my hospital. So I think it is just mind-boggling that you have people living around you in a huge hospital and they are coming late with insurance in their pockets, which is proving the point that having an insurance card in your pocket is not enough. We need to outreach to them. So I think that is an example where Richie said, your zip code is very important. Where do you live?
And for those who may not be making the connection, explain why it's significant that these people have health insurance and are coming so late, meaning that there are detection methods that they could have been getting earlier. Explain a little bit.
What we did on the first year of this project is to go out to the community, and we completed almost 1,200 questionnaires, asking many questions, but one question was important. The question was, why do you think women are coming late to the hospital in spite of having health insurance? And they wrote, it was an open-ended question. And the number one reason was fear. Fear of diagnosis, fear of having a mastectomy and being led by their husband. So they wrote so many different fear responses. And the number two reason was personal reasons, like I have no time, I have to take care of somebody else. And number three was fear to the mammogram. People in the community, they feel that because mammograms, they release radiation, they produce cancer. It's unbelievable, but that's why they believe there. So this work is showing us that what we need to do is to do community outreach. We need to be at the neighborhood. Mm-hmm. So the hospitals, all hospitals, they need to take care of the neighborhood first.
I think that's very important. I mean, the Mayo Clinic has published last year a study that cancer is still the most feared disease. Now, it's been 46 years since President Nixon declared war on cancer in December 1971. We have developed more than 500 cancer treatments, and the world spends more now than $1 trillion every year in cancer costs. And still, cancer has remained such a traumatic experience, and the number of new cancer cases globally is not letting up. I mean, in fact, the WHO predicts that the number of new cancer cases in 20 years will be 70% higher than today. So this will only change if we refocus or create an additional focus of doing something before cancer occurs. Only then we can stop essentially the increase and start eliminating cancer. And only then cancer has the chance to not become the most feared disease, because then you will have safe preventive therapies.
In addition to research, developing new techniques and treatments or interventions for prevention, we need to educate people. We are seeing this with HPV vaccine. When I was in medical school, my professors used to tell, you guys are going to see one day your lives a vaccine against cancer. It was a dream. We have it. And the uptake of that vaccine is 40% in the US.
We have done market research at the foundation and found out that really a large part of the reason is that the pediatricians and other primary care providers are not messaging correctly and appropriately to the parents of the 9 to 11-year-olds who should be getting it, initially anyway. It's just sort of, they kind of equivocate, and they don't give a strong message. Next year, your child's going into 6th grade, and next year your child should have Tdap and meningococcal vaccine and HPV. End of story. If there's pushback, then
only
yes,
one of
discuss
those
it.
3 prevents cancer.
Correct.
Right.
That's exactly right. And it doesn't just prevent cancer, it prevents 6 kinds of cancer. That's another educational message that needs to get out there, because I think most people associate it with cervical cancer, if they associate it at all. But that's one thing, I think. And I think we have got to tackle the obesity epidemic, because if I'm not mistaken, it's estimated that, is it by 2030, Rich, that obesity will surpass combustible tobacco as the leading cause of cancer death.
Here's what we know without any doubt. It's second right now.
Right.
And not terribly far behind tobacco as a cause of as a cause of cancer, not just preventable cancer, as a core cause of cancer. And combustible tobacco is at an all-time low, which is terrific. Hope that we have to keep working to keep that trend going. And obesity is continuing to rise. So
Exactly.
I think
And in children. And we've got to do something
beginning
about
in
this next
childhood,
generation.
adolescence, right through adulthood. We kind of know some proven strategies for tobacco control where we have to find the proven strategies
Absolutely.
for calorie control, more exercise, achieving energy balance.
Thomas, your work is at the intersection of where the education and access meets the science. Do you want to say a little bit more, especially for inherited cancers, what your work is focused on?
Yes, we are focused on developing preventive therapies for inherited cancer. As an example would be to develop a vaccine that teaches the immune system in healthy people who have a BRCA mutation to not develop, to eliminate precancer cells before these precancer cells turn into cancer cells, so that these BRCA or carriers of a BRCA mutation would not even develop cancer. And that is something that we can focus on in one cancer like BRCA, which is an accelerated cancer, and then learn a lot for also other cancers. And I think, historically, there was a historic scientific hurdle to prevention, which is in cardiovascular diseases and heart disease. We knew 10, 20 years before somebody gets a stroke, there is a high cholesterol, there's a high blood pressure. We had companies that focus on lowering it. But we didn't know as scientists what happens 10, 20 years before somebody is getting cancer. It was even worse. We didn't even know who will get cancer, so we didn't even know whom to study. And so in the inherited cancer community, unfortunately and fortunately, yes, we did not have that marker.
We didn't have cholesterol for cancer.
But in inherited cancer, we have that marker. We know there is a population of people, a community that unfortunately has a very high risk. And now we can explore these precancer cells and what they look like, and then do a very similar thing that has happened in other cancers. So we can teach the immune system, we can develop therapies that increase DNA repair. So that's now possible, but we need to get more effort and more focus from the community, from the scientists, and from the industry to actually make it happen. But it's now within reach.
Dr. Bircha, I want to go back to the work that you're doing at the Preventorium. You talked about breast cancer screening and tackling that right around the hospital center. I know as part of the Cancer Moonshot, your hospital also made a commitment around colon cancer screening. Do you want to describe what that was and how that's going?
Yeah, it's the same concept. After we found out that 97% of women who had stage 3-4 breast cancer who came to my hospital, they have health insurance. So we went just to see our own data and to find out who were the people with advanced colorectal cancer who came to my hospital. And it was worse. 99% of them have health insurance, and they are coming with advanced colorectal cancer. So we developed the same model, which is to get community health workers who are people who are not health professionals. They live in the community, but the advantage is that they know every corner of Ward 5 where we are doing our work. So they know the 7-Eleven here, they know the store here, they know everything. So they are outreaching, and we are going to many places in the community, offering people after an educational session, on one hand, who wants this FOBT? And we, of course, we show them pictures, the poop, the whole thing, because people, they don't see this. When you talk to people about FOBT or fecal alcohol blood, they imagine one thing. But when you show them a picture of a toilet in which there is a piece of paper and there is feces there, and they have to do this test, they say, my God, is that what I have to do with this little thing? Yeah, and you send it over the mail. I get the report. They take it. So we have now this almost 40% return rate in the FOBTs we are doing in the community. So that's the educational plan that we have, which is use community health workers, go to the community, release and these educational sessions and offer either FOBTs or colonoscopies. We are also doing colonoscopies, and we found one case of cancer. One gentleman who in a church, he got the FOBT, it was positive. He went to the colonoscopy and he had an early rectal cancer. He just had surgery, robotic surgery, and he's so grateful because of the program.
And Elmer, you mentioned church, and I think one thing I wanted to mention is that we just should not discount the value of the faith community in helping particularly underserved and minority populations, because they are a trusted source of information for everything, not just spiritual information, but also their physical health as well as their spiritual health.
And you know what?
We've done many programs with churches at our foundation, and we have found that that's one place where there is this complete trust.
Rich, I want to go back to you. We're talking about how local a lot of these solutions are. As a national organization, how do you try to balance that and reach into these communities and find effective ways of carrying the message and the education and access that you all provide at ACS?
You know, I think there's a very balanced, and now I would confidently say evidence-based approach of combining national efforts with that get translated locally. So let's stay in the colorectal cancer field. As many people know, at the National Press Club in March 2014, with the Assistant Secretary for Health, we launched 80% by 2018, which was a campaign to achieve 80% colorectal cancer screening rates by the end of this year. It was organized by the National Colorectal Cancer Roundtable, which has now over 100 member organizations. That's an organization that's administered by the American Cancer Society and funded by CDC in part. But it's really those member organizations and the volunteers who served on the task forces that have produced tools. And I encourage people, if they've never gone on the nccrt.org website, they need to do it, because there is a tool for every audience, and I mean literally every audience that they can possibly imagine, every strategy. They're just tools. They only matter if they're taken and then translated to the state level, local level. We now have 80 by 18 pledge signers in all 50 states, in Guam, Puerto Rico. We have some sort of consortium or state-based roundtable or comprehensive cancer control effort in all 50 states. The day before we're filming this, I just came from New Orleans at the Southeastern Colorectal Cancer Consortium, 13 states from the southeast part of the United States. This is their third annual meeting, and they have teams from every state, and they're looking at tools, coming up with specific strategies. There is a ground game, and we're fortunate at the American Cancer Society that we have staff in every state who are working with primary care and state health systems and hospitals who are bringing their expertise in quality improvement and public health implementation. So it demands a really broad effort, but it's so gratifying because colorectal cancer screening rates had plateaued before we launched this, and now they're going up again, which is fantastic.
So that brings me to something I'd love to hear from the rest of you on. What people watching this, what can they do in their personal lives? What can they do in their community? What can they do at the state level to make the most impact on these issues from your perspectives? Rich, I think, just gave some great tools and examples of how ACS is doing this, but from each of your individual kind of viewpoints, what should people be doing to make a difference on these topics? Thomas, do you have thoughts?
So one thing is think about your own health and make it an important topic in your life, whether it's about obesity, as you mentioned, or nutrition, but be interested and engage. So make it, because, cancer is a disease typically of the 60, 70 and older, but the maintaining health and preventing cancer is something you have to take care on as a young person. And that's a different mindset. It's not dealing with patients with cancer, it's dealing with healthy people to not get cancer. And so everyone needs to engage and be interested. And then I would say also engage that this field is moving on. Please try to find an organization of choice that is actually trying to make an impact and hopefully also making an impact to move this field forward by either creating awareness and helping the momentum by collaborating and the others who bring researchers and industry and patients together to actually develop these therapies. You can save lives by making sure everyone has access to the best standard of care. You can save lives by making sure that the standard of care gets better and better. These are the two things.
Well, I think we want to tell people exactly what they can do. We want to get that message out. What are the steps you can take in your daily life that are going to help you reduce your risk of cancer or detect it early when it can be successfully treated? So we want people to understand screening guidelines. We want them to understand vaccination guidelines. We want them to understand that they should never use tobacco in any form, that they should practice sun safety, that they should maintain a healthy body weight, and that they should eat a nutritious diet and engage in physical activity to the extent they can every day if they can, and to know their family history. And if they can do those, that was 8, if they can do those 8 things, they will go a long way to reducing their risk of developing cancer.
One thing I'd add is almost all of us are part of some sort of community, some sort of organization, and we need leaders. I love what Elmer said, that can you just imagine, and this is a passion I share, if every hospital said, our first priority is to take care of the community in which we're located. Mm-hmm. That's our first priority. We're going to tackle that. No matter what else we're doing, we're going to take care of the people who live around us. And I would say define that denominator broadly, not just the people who happen to have a primary care doctor. Really understand your neighborhood.
What we have to do, all professionals who work in cancer prevention, is sell, quote marks, these concepts in terms of lifestyle. To have a healthy lifestyle, to comply with the guidelines that Bo just mentioned, is a very, very rewarding experience.
So as we close, I would love your vision of where we could be in 10 years in prevention and early detection, and how do we work together to get there faster?
Well, my hope and vision for in 5 years would be that we really have one collaboration, a huge collaborative momentum for prevention, for cancer prevention, because that's really what it takes to shift the paradigm. Mm-hmm. And I see a lot of, elements and movement in this direction. So I'm very hopeful, and the Biden organization, I'm sure will and can make a huge impact. Okay. The second part is, in 5 years, I would like to see 25 candidate therapies, medical compounds being developed in major clinical trials to prevent cancer. We need to scale this and find really the best ideas from anywhere across fields, geographies, sectors, and then turn them into preventive therapies. And that's really where this momentum should be directed.
I would say that we need to maybe start a step back and have individuals and groups of individuals understand the need for that. And then they can come together and effect this large collaboration that you're talking about. But first, I believe it has to start with the individual, the family unit, the sort of local community, and then understanding why prevention and early detection are so important. I think there's a lot of people who still do not believe that cancer is a preventable disease.
Getting the message that up to 50% of cancers can be prevented.
Yes, oh, absolutely.
Like this is half of the population who currently will get a cancer diagnosis, that you all are working hard to spread the word and develop the technologies that make sure that that doesn't happen.
And one other constituency that I think is often overlooked and is really important are cancer survivors. We've done a lot of events where we're just talking to the public, and we offer people information about cancer prevention. They say, I don't need it, I've had it, I've already been. They really don't understand that they are at higher risk of getting another primary cancer if they've had cancer already.
My family is part of 1 million Americans who carry a BRCA mutation. So you have an up to 90% chance of not only 1, but 5 different cancers. So there's a level of urgency. While we educate, we need to act right now. And so we need to create the momentum, but there are always early adopters and visionaries. They have to move now so that we get the first preventive therapies when the momentum in society starts to want them almost.
In addition to educate, that I think we all agree, give the concept, we need to somehow provide services that focus on prevention. one of the main reasons for people not having FOBT, colonoscopies, and mammograms is because the primary care doctors, they don't order these tests. So in addition to that, I think we need to explore the idea of having clinics or centers for prevention. Only for prevention, for people who can just go and have a checkup like we're having now in the stores, like big retail stores. They have these little clinics. Maybe we can explore some ideas on doing that.
The only thing I'd add is, we have some incredible momentum right now in prevention, and this is a good moment for everybody to get on board with the things where we're seeing real progress. Combustible smoking, cigarettes, all-time low, and the nation has launched Mission HPV Cancer-Free. There's real momentum around HPV vaccination. And then while we're taking advantage of that existing momentum, we have to start building capacity, make sure we focus on the persistent disparity in breast cancer with blacks dying at a higher rate than whites, increasing the percentage of heavy current and ex-smokers who have the chance to be screened for lung cancer. And as we've said all through this, we need to start understanding some strategies that are really effective around the epidemic of overeating and under-exercising. And individual behavior will be part of it, but clearly there are environmental roots to this. We're going to need to understand.
And cultural.
Environmental, and it's going to need a multi-pronged approach to do it.
If I may add one thing, when I look back 20 years ago when I switched from academia to the biopharmaceutical industry, at that time nobody wanted to invest in the industry in oncology because you had these big diseases with hundreds of millions of patients and cancer was too complex. Now it worked. Then you started to actually focus from breast cancer, lung cancer, you started to focus on orphan cancers like multiple myeloma, like CML, Gleevec, and so on. So everyone said it will not happen. It did happen. Then you dissected essentially with precision medicine those smaller cancer to even smaller population. People said it won't work. It did work. I believe prevention is that next phase, and I think for prevention, yes, we can do it.
Well, thank you all. I think given that, as we said, could prevent, up to 50% of cancers can be prevented. This topic is just as, if not more important than all of the rest of the topics that will be taken on. I know the Biden Cancer Initiative looks forward to working with all of your organizations to keep this going forward. And we hope that the folks in the community listening to this and working on their own ideas tells us all about them because I think we have an open audience here to more ideas and more innovations that we could take going forward. So thank you. Thank you all.
Thank you for what you do.
Very much.